It's really humbling to see a group of people like this and to get a connection with the patients whose images you're looking at every day. And even talking to, and the people I talk to know who you are, but I recognised some of those stories and I know that I interpreted some of these people's scans. So thank you for that opportunity again. Look, what I wanted to talk about today is, I'm lucky that Remy has actually already set me up by explaining to you what a radiology does and providing such a clear description of some of the tests that we can do. But what I wanted to go through was how we use imaging, in particular MRI, to help make the best decisions for you. Whether you are concerned you might have a diagnosis of prostate cancer, you already do, or you've had treatment and you want to find what the next best path forward is. And one thing I want to emphasize here, and we'll repeat this theme throughout this short presentation, is that imaging is only one piece of what we're doing here. Choose your metaphor. It's only one tool in your toolbox. It's only one arrow in the quiver, one weapon in your armory, whatever. But these things need to work together in order for them to be of maximum benefit. Now, I put that diagram up there. That's not to suggest that they're equally weighted. In some patients, the clinician's opinion, their examination findings are going to be enough and drive the process forward. In others, it will be PSA. In others, and we'll see in some of the examples I give you later, imaging might actually be the thing. Of course, it's hard to argue with a biopsy that's definitive, but sometimes the biopsy won't give the answer because they didn't biopsy the right part of the gland. Now, there are several reasons why you might get an MRI of your prostate. I just wanted to go through a few here today. You might be able to avoid getting that needle in the first place. There was a big trial that came out a few years ago called the PROMISE trial, which suggested that up to 25% of men who would normally be considered for biopsy could have that biopsy avoided. That's, when you're talking about the amount of biopsies that occur, that's a lot, right? Now, that's not saying you can go home and forget about it for life, but they're saying for that period of time, you might not need a biopsy, and just keep monitoring the PSA, keep seeing your doctor, keep trucking along. Now, another reason might be that we want to be able to target the biopsy. Traditionally, prostate biopsies have been done blind, I guess is one way of describing it, but you'll sample the gland as much as you can, but it's not like a biopsy of something like a breast lesion where you know exactly where you're going. You can feel a lesion or see it on imaging. You try and biopsy that. So what we can do is provide a target for the urologist or radiologist, whoever's going to perform the procedure. And the other indication there would be that you've had negative biopsies in the past. So we do an MR to try and find out whether we can target the biopsy. Active surveillance. If you've had a diagnosis of prostate cancer that's thought to be low risk and you would like to have another scan, maybe every 1 or 2 years in concert with repeat biopsies, we can do that for you. And then the last main group would be staging. You have a diagnosis. We want to be able to provide you with some more information as to whether it could be treated surgically or perhaps some other option. Now, I just want to try and draw your attention to this very important concept that I'm sure everyone is familiar with, but what I'm talking about here is what we'd consider to be clinically significant prostate cancer. That's a cancer that should require treatment or is likely to have some kind of effect on your life. Now, the problem is there's no perfect definition of this. Definitions do exist related to volume or grade, but we don't exactly know what it is. We do know that there are some cancers that you'll be okay without any treatment, and we know that there are some that you will absolutely need treatment, but the margins can be blurry. When we're talking about identifying cancer using MRI, this is what we're talking about, what we'd consider to be clinically significant. And I'll put the word cancer up there just to try and drive that theme forward, right? Cancer is a word that has so many connotations, but it's not one disease. It's 15,000 different diseases, right? And even all the prostate cancer that people have had in this room, some of it will behave very similarly, but also, as you know, some of it is incredibly different. Not one condition at all. And the other thing to bring up while we're talking about clinically significant prostate cancer is this concept of overtreatment, right? Certainly we know that in the past we've offered reasonably aggressive treatment to men who may not have needed it. And we have examples from other malignancies where we know we've overdone it in the past as well. So what are some of the good things about MRI? Well, no needles, maybe a little prick for your Buscopan. We can give that to you in a muscle or through an intravenous injection, but not a needle like a prostate biopsy. And it has what we call a good negative predictor value. So that means if we say there is not a clinically significant prostate cancer there, it's very likely to be true. Okay? Nothing is 100%. But that is the reason why we can say that you might be able to avoid a biopsy. Good predictor of no cancer. Some of the weaknesses, I'm not here to tell you that it's perfect, it absolutely is not, and that's why it needs to be part of a suite of different tests or clinicians or other things that you can use to try and maximise your diagnostic yield. Its positive predictor value is not as good. Now what that means is that if we say there's a lesion, it's not always going to be cancer. It might be infection, it might be scarring, it might be inflammation. It will miss some clinically significant prostate cancer. Now, there's no clear guideline on what that number might be. It might be around 5%. Some people think it might be as high as 15%. And of course, when it comes to staging prostate cancer, it's limited. You're only looking at the pelvis. Basically, you're looking for local invasive or metastatic disease, but it's not going to find those distant bone metastases because we just don't scan that region. Now, for those of you who have been around a while, you might remember that MR prostate came and went at some point in the last 10 to 20 years, probably about 20 years ago, and I just wanted to quickly touch on that. MR prostate, in its first wave, was a very different beast. It was time-consuming, it was complex, and difficult to perform. And that was because they were doing something, well, very broadly, it was because they were doing something called spectroscopy that can be difficult and turned out wasn't particularly useful for prostate cancer imaging. What really changed and what has driven this second wave, if you like, is diffusion-weighted imaging, which is a technique that enables us to identify differences in tissue. Essentially, cancer tends to be a more dense tissue, and we can find this density using this technique. Right, so what I wanted to do now is go through a series of cases, similarly to how we might look at them in an MDM or an MDT, and try and give you the clinical indication, and then, if you like, the answer, or at least where we got to. So case number 1, 69-year-old man, PSA of 7. No prior treatment or biopsy. This might not look like much to you. It looks mostly black, right? And in this case, that is very good. What we're looking for here are some bright spots. We don't see any. This is another way of looking at that same information. So this and the prior one are not what we'd call anatomic. They're not those beautiful pictures that Remy showed you of detailed prostate. This is, right? This is our anatomic sequence. And even here, what we can see is a relatively normal looking prostate. It does have a nodular hyperplasia, so it's an enlarged gland, but we don't see a suspicious lesion. So in this case, this 69-year-old gentleman got to avoid a biopsy. And as I said at the start, and I'll keep repeating, it's not all about the MRI. His PSA was 7, sounds high. His PSA density, so the PSA level related to the size of his gland, was actually not too bad. And the patient and the urologist find that reassuring, as well as the lack of a lesion on MRI. Second case we'll do, similar clinical scenario, similar age, 66-year-old man, PSA also going up, starts higher at baseline, right? So PSA of 11.3, and this patient had had a negative biopsy in 2016. This is the bright stuff we were talking about before, right? So this is catching our eye already. We think there's going to be a lesion here. Backed up on the next part, and on the anatomic sequence that we showed you, that I'm showing you, you can see a lesion on the left side of the prostate. For reasons that I cannot entirely recall, this man also got a PSMA PET-CT. It matched the MR beautifully. This is just the MR with the PSMA uptake overlaid on top of that. And you can see there's a match for the lesion. So what we get to do here is target the biopsy. And this patient ended up with an ISUP 2. So that would be a Gleason 3+4. And I think went on for a radical prostatectomy. All right, case 3. So this is active surveillance. 61-year-old, an ISUP 1, so a Gleason 3+3 that had been biopsied a few years ago from memory. What is definite is that it was on the left. So we do this test. Again, we're looking for the bright stuff. This one, it's bright enough for a radiologist. It doesn't quite stick out the same way as the previous one, though. sticks out there, right? There's something different going on. And on our anatomic sequence here, you can see a relatively conspicuous lesion. Note that it's not on the same side as the previous biopsy. So what we've got here is MR showing that there's a discordance between the biopsy result that we knew about, low grade, small volume, and what we're seeing on the MRI. So using the exam here, we were able to target the biopsy, and it turned out to be ISUP3, so that's a Gleason 4+3 malignancy. Fourth case we'll talk about, different scenario again. So this is staging. 80-year-old gentleman, PSA of 24, as you know, very high, could indicate metastatic or locally aggressive high-grade disease. The biopsy got cancer out of both sides, and again it was a 4+3, ISUP3. Lots of bright stuff here, right? It's not like the other MRIs that I've shown you, which just had a small focal lesion. Here, almost the entire gland has been replaced by abnormal signal. So you can see some white stuff there. That's artifact. This gentleman has a hip replacement. We can talk about that in the questions if you like. Hip replacements can make MRI a little bit more difficult. Lots of darkness there. And this is the anatomic. Well, you guys have seen a few MR prostate slides now. You probably think that this one doesn't look quite like the rest. It's just a grey blob. Almost the entire gland has been replaced here. Also, the tumour has extended outside of the gland, so it's what we'd call extraprostatic extension. And in addition to that, we do include the whole pelvis when we do MRI prostate. I put arrows around a really big node on the right there in the pelvis. So this has taken this gentleman out of surgical management and into medical. All right, so we'll go on to the fifth case here. This is another staging case. 50 years old, PSA of 12.4, ISUP2, so Gleason 3+4 on the right. Probably can't see anything by design, right? Not much on this one. I put dots around that instead of the circle just to indicate that there might be a finding there, but considering there wasn't anything on the first two, on the basis of that MR, we have nothing to call. So we know this gentleman has cancer, but we can't see it. Because of that, he ended up having a PSMA PET-CT. It did see it. You can see the uptake in that spot, funnily enough, where there might have been something on the MR, but not enough for us to call. So what I wanted to show you here is that this test is not perfect. There will be cases where the MRI is negative, even though we know there's an underlying lesion, and potentially there's another test that can show the disease. And this guy, there was a good result from the PSMA scan. It was locally positive, but there was no metastatic disease. It does go the other way, though. Don't think that PSMA is always perfect and MR is not. We've got other examples where the MR is positive and the PSMA is negative, and I can talk about that a little bit later. Right, second last case. So 68-year-old man, PSA has been going up. We suspect that his cancer is progressing. The catch is that the only positive biopsy result we have is a Gleason 3+3 or ISUP1 from 2015. Had a negative biopsy between now and then in 2017. This looks different, right? Looks different to the other cases that we've gone over. This isn't just a lump and it's not the whole gland, but there's bulky tissue that it looks bright. And on the anatomic sequence here, you can see that that's at the back of the gland. But there's one other thing in the middle here that is actually a catheter, okay? Now at this point, this was reported, the scan was reported as saying there's a large tumour. They still don't have any biopsy confirmation, right? So we have to go back to 2015 where we've got a cancer that is not necessarily something we would expect to look like this. It could, of course, progress. But at this point, there's still this assumption that the cancer has got much worse. So he goes on and has a PSMA scan. Nothing. Remy and some of the other people in the room will know what's going on. But what is actually going on here is we can have false positive MRIs. In this case, it's because there's inflammation of the gland. The patient has a catheter in, it's probably low-grade bacterial seeding, he's got inflammatory changes in the posterior part of the gland itself. But this is also an example of what can happen if you let things run away without following normal procedures, right? So after he had that MRI, he ended up getting a bone scan, which reported a rib metastasis. So this patient thinks, oh my God, my cancer's terrible, I've got metastatic disease. Getting everything sorted to try and come up with an approach for treatment like that. Gets a PSMA to identify the extent of the metastatic disease, and of course, it doesn't show anything. The bone scan thing reported as a rib metastasis was a fracture. And a repeat biopsy showed that the changes on the MRI were inflammatory only. So it's a good result. Case 7 is a little bit different. This is the last case we're going to go through. Now, this is an entirely incidental finding. 71-year-old gentleman, PSA of 1.9, not particularly concerning, right? And as I said, no real reason to do it. I'll tell you how it happened in a moment. Now, these pictures aren't quite as nice as some of the other ones I've shown you. It might look a little bit more grainy. But take my word for it, there's just a slightly more signal where that red circle is, so that makes us think there's denser tissue there. And that was backed up on the anatomic sequence as well, even though the contrast between the two sides isn't as nice as you might think it would be. Well, that's actually my dad. And the reason we did that is when he was visiting one time, we were setting up the protocols in a new scanner in Christchurch here, and we were trying to develop a scan technique not dissimilar to the prostagram like Remy was talking about. So they were done quickly. That was a 10 to 15 minute examination. And I'd been through everything with Dad. You know, it's always a bad idea, as Tony had said, to do these tests outside of a normal circumstance. But I'd had a chat to him. I knew his PSA was very low. I knew there were no symptoms. I told him that there's a chance that we'll find something. I didn't think it was going to be prostate malignancy, but we could find an incidental thing that would generate more work, and potentially we could find a prostate malignancy that may not have been something he wanted to find. It's that classic dilemma in medicine, right? Anyway, he ended up having it biopsied. It was a 3+4. He had brachytherapy as well. He's very grateful, he's very happy, and he's doing well 2 years later. Now, I touched on this before, MRI and PSMA. I think there's a great potential for these techniques to be complementary in the future. There's a trial that's been run predominantly out of Melbourne, but we're involved in scanning some of the patients for too here in Christchurch, where patients who would normally get a biopsy are instead getting an MRI and a PSMA pre-biopsy to see if the PSMA can help increase the diagnostic yield. We certainly don't have anywhere near enough information for me to answer that question for you, but what I can tell you anecdotally is we've got a handful of cases now where, as I alluded to before, PSMA has been positive, MR has been negative, or MRI has been positive and PSMA has been negative. So again, go back to that slide I put up at the front. You've got to use all the tools in your armoury. Remy touched on this, but in my opinion, I would like to see a sunsetting, if you like, of these investigations as routine standard of care in prostate investigations. Bone scans, as Remy said, are insensitive and non-specific, and we had a nice anecdotal case of how they can get you into trouble here. CT staging for the reasons that Remy said as well. If you have low-risk disease, it might be entirely appropriate. But if you're intermediate to high risk, we just can't say whether you have nodal or bone metastases on the basis of a CT. So what we want to be able to do, by doing good quality imaging, of course, is to have it be one part of that suite of things to get the correct answer for the patient at the right time, and to enable them to make the decision and guide them towards the treatment that best suits them.